the land on is the unceded traditional and ancestral territory of the Coast Salish people, including the Musqueam, Tsleil-Waututh, and Squamish nations. I encourage you, if you're calling in from any lands you would like to acknowledge, to do that in the chat. We'll be happy to acknowledge those also. So today we're going to be discussing or giving some form of conceptual background to the idea of digital public health and what it should mean to us as practitioners. I think during COVID-19, it became rather apparent that digital interventions could create an ecosystem that helps to inform very effective public health responses. So, for example, it became apparent, and Christopher Murray at the Institute of Health Metrics and Evaluation at the University of Washington suggested that digital public health had the potential, or huge potential, to accelerate effective public health responses to pandemics. And thereafter, we started thinking about ways we could apply these same functions to other public health activities that we were involved with. And so today we're going to set some form of conceptual background to some of the conversations that we'll be having in the course of this seminar series over the next month or two. Today we hope to describe the various perspectives that people have on the idea of digital public health. We will describe some of the challenges and opportunities for digital technology across various public health functions. And then we hope that by the end of this session, you would understand how fundamental public health principles might apply when you consider digital technologies within your public health practice. Just to give a little lay of the land, we have, and I'm excited to have friends and colleagues around the world who are involved in this similar practice as we are here at the UBC CDC. So we'll have a conversation first, establishing some conceptual background, and I will do that short presentation. Then we'll invite Stefan, who's been involved with the European Public Health Association's work with digitalizing public health, and he's drawing on examples from his work within Malta. Then we'll look at systems perspectives. How can we understand from a systems perspective whether or not digital systems are mature enough to engage with digital technologies, and how we can set them up to better do so, and what competencies we might need to actually achieve these functions. And so Laura from the Leibniz Science Campus at University of Bremen will discuss that. I'm excited to also hear from Elida. Elida is a postdoctoral fellow at the Leibniz Science Campus also. And some of her work really explore the alternate side. So many times we have this techno-optimistic view about the role of digital technologies in public health and how we can be leveraging technologies for public health function. But widespread digital transformation also has implications for our public health practice, implications for public health outcomes. And so Elida will be describing some of her work, understanding the implications of digital technologies and people's exposure to them in terms of their health outcomes, cardiovascular outcomes specifically. And then finally, Felix will describe some digital public health interventions within the field of pandemic or epidemic and emergency preparedness. So understanding how they've been able to leverage informatics and informatics platform to accelerate public health responses within situations like currently exist in Gaza, for example. So we'll start by just trying to get a sense of who's in the room. If you've got your phone, you can quickly scan that QR code, or if you go to slido.com, you can enter that number, #1721671 into slido.com. We'd like to just get a sense of who's in the room. It will give us a fair sense of how we can tailor our conversations today. I'll just give this another few moments. Okay, well, I think we'll have the opportunity to understand who other is when we get into the breakout sessions. But I see fair representation among researchers, students, and practitioners. We'll hopefully be able to give a broad enough description of what we're talking about today without necessarily going into so much detail. Hopefully, at the end of this session, you would have a list of materials and resources you can explore more deeply to get a sense of what we're discussing. Before we start, I know you got notices about this event. You saw the term digital public health within the invite. I'm wondering what came to mind when you saw these invites. What comes to your mind when you think about digital public health? You can use a word or two. I just want to get a sense of where our minds are at currently. Again, you can use the QR codes up top, or you can just go to slido.com. Okay. And enter 1721671. Okay, so I see lots of conversations around knowledge translation, accessibility, some conversations around rapid response data, yeah, dashboards, informatics, automation, efficiency. I really like that this group is grounded. I was expecting artificial intelligence to be really big up top because it's the rave of the moment, but I really
yeah, now someone will include it,
yeah. Efficiency, yeah. Data, knowledge translation. Okay. All right, so I think I'll stop here, but you can still let us know what you think. I'll always have access to this information, and it can inform how we think about this going forward. But let's just start. The work we're going to be describing today, at least for us at the UBC CDC, this does not account for all the other great minds and the lots of work that has gone into this work. But for us, it started with really thinking about what digital public health might mean to us, because at the time we're trying to establish a digital public health unit within the organization. And so at that time, with funding from the Pacific Public Health Foundation, we try to define the scope of digital public health and its implications for policy, practice, and research using a scoping review. So we explored the literature, trying to understand what researchers, practitioners were sort of describing as digital public health, or what their conceptual descriptions of digital public health was about. To give a brief history, digital public health was first made popular when Public Health England, now the defunct Public Health England, in 2017 describes its digital first public health strategy. And when we did look at the literature, we found that there were essentially two main descriptions of what digital public health means to different organizations. So the Public Health England description is that they were thinking about digital public health as sort of a reimagination of what public health might be in terms of its goals and functions, blending established public health wisdom methods with new digital concepts and tools. So essentially, sort of rethinking how public health should be practiced cognizant of the role that digital technologies play both in society and the way we actually implement our functions. The European Public Health Association, on the other hand, sort of described digital public health not necessarily as a discipline or a field per se, but an asset, something that we can use to achieve existing public health goals. So the aims and goals of public health not necessarily change. We just try to become more efficient through the process of digitalization. And these two descriptions sort of align with two different processes going on within society. So, for example, the process of digitization, which is something I'll just mention as a throwaway term, is the process of converting analog records like, paper-based health records into an electronic version of those same records. It's not included in the process of creating data. It's just a process where you transfer one analog piece into an electronic piece, and you can, for example, do further analysis with it. So think about someone transcribing paper records into an Excel file and then being able to analyze further. But digitalization goes beyond that to include digital technologies within the process of data generation. So think about creating electronic health records where people can access these records in the process of receiving care. On the other hand, digital transformation sort of was positioned within literature as sort of a more broad and all-encompassing process where not just each digital tech, not just each service point receiving this digital transformation, but the whole system being reorganized with the user or the health users in mind, leveraging technology around across the board to be able to then increase efficiency of public health functions. Within literature, there are many examples of this. So, for example, think about a health strategy where health records are integrated with technology, but then these health records are integrated with health apps where users can access their personal health records across systems. But then all of these records are also pulled automatically pulled into public health systems to inform dashboards and decision-making processes. This sort of across the system end-to-end integration of technology will require organizational changes, will require changes in culture, on the way we think about our work. And so that really forms the point of digital transformation. And so within the literature, there was debate around whether digital technologies might enable all of our functions or whether they might be supporters, aligned with the UFA's description of digital technologies as more or less supporting existing goals. Sometime during the last few years, as we've tried to explore digital public health, one of the questions we keep getting is, how is it different from digital health? And I pulled this slide to sort of suggest that these questions are not new. Levesque and colleagues in 2013 sort of showed that there are intersections between public health work and primary healthcare, or healthcare generally speaking, where public health work is focused on health outcomes within the population and within public. So it's organized action to secure public health. Whereas healthcare or primary healthcare is really focused on the individual, aligning functions to ensure that individual health outcomes are improved. But there are intersections. So for example, to deliver, for example, immunization services, it's both a public health role, but also you need to interact with individuals within the clinical setting to be able to deliver such immunization. So there are many areas of intersection. And so if there are many areas of intersection between health and public health, then there are potentially many areas of intersection between digital health, which is really focused on that individual client level client level delivery of health services, versus public health, which is focused on population and public health outcomes. And these questions are not new. In fact, I am happy that Laura from the Leibniz Science Campus is here. they've done a lot of work thinking around what constitutes a digital public health intervention versus a digital health intervention, and how there are differences but also similarities between the two, and how we might be positioning systems to drive interactions between both to ensure that health outcomes both at an individual level but also on a population and public health level are secured. And I won't speak too much to this slide because I think she'll do justice to it. But on our end, we sort of try to itemize some of the differences we see. And this is drawing from the literature. So for example, in terms of perspective, like we said, digital health interventions focus more on ensuring efficient, effective healthcare at the individual level, and really considering individuals' perspectives on their care and their goals of care. So that person-centered care perspective. Whereas digital public health interventions will really focus on the population and public health perspectives, improving health of populations, creating interventions that are more or less people-centered rather than person-centered. In terms of context, so digital interventions mainly will be in the clinical setting, may follow individuals into their communities, but it's mainly clinical, whereas digital public health interventions are within the community and really specifically are trying to engage people in different populations to ensure their health outcomes are optimized. And so because of these differences in goals, the interventions might look slightly different. So individual apps, individual health records or personal health records that support care at the individual level versus more public health goals like dashboards, analytics for public health outcomes, but also looking at outcomes on a population level like environmental exposures, using things like GIS or geographic information systems to track these outcomes. But for us, what's really important is the place that health equity plays. So while health equity is acknowledged and is really important for digital health, it's not necessarily the main goal. Individual goals are still important, but for digital public health intervention, the focus here is ensuring that equity is central to whatever we do. So when we talk about equity and within the digital public health space, then brings us to a few more conversations that we must have and think about in relation to digital public health. So first off is the concept of the digital domain as super determinants of health. So this paper by the US Substance Use and Mental Health Services Administration describes how access to digital services, digital devices, broadband internet access are fundamental in not just directly ensuring people's access to digital technologies or digital health interventions or digital public health interventions, but also access to income, access to employment, and access to education. And so it plays both a direct role in how we access health and health outcomes, but also an indirect role in terms of then securing the economic or the resource needs that then help us secure health outcomes. Van Kessel, a known friend of this group, also published another piece identifying digital health literacy as another important super determinant, because when people are able to have access to these technologies, then they need to be able to use these technologies to secure both access to health services, but also then access to additional health outcomes and employment. But flipping that coin over, there's this quote by a prominent data scientist, which then really helps us think about the impact of digital transformations in society. So Jeff Hammerbacher at Cloudera says, the best minds in our generation are thinking about how to make people click ads, and that sucks. There's digital transformation going on in society, and that has implications for health outcomes more broadly than we can actually think about in current terms. So for example, over the last 4 years, the US Surgeon General has issued at least 2 advisories suggesting that because people are exposed to social media, there are significant impact for youth mental health, especially because these apps prioritize time spent on the services rather than quality of time spent. And so because of that, there's a risk of isolation, depression, anxiety, and this is actually reflected in the data currently. Thankfully, I've got Elida Sina here also, who describes some of her work and the impact that people's access and exposure to digital technology will have in terms of cardiovascular well-being. So in some of the work she's done, she'll describe how people's access or the time they spend on social media and their exposure to social media does have impact on risk of metabolic syndrome and other cardiovascular diseases. And so now that there's recognition of these potential risks, we must be thinking along the lines that while people's access and literacy will ensure that they have access to digital health or digital public health services, that access is a two-edged sword in that those who have access to these technologies also have risk for exposure to exploitative content and exposure to untoward or other disease outcomes. And so we must think about digital determinants of health, not just in terms of access and in terms of literacy, but also in terms of digital transformations and how they are changing literacy, education, housing, access to health systems on an individual level, but also changing access to information. During COVID-19, there was a real understanding of the impacts that these systems might have in terms of health outcomes. And then how these services, as they provide front-end services to us, also have significant implications for the environment. So I don't know if you've paid attention to the environmental impacts that large language models do have, but there's evidence, for example, that some of the large language models can run power equivalent to some small European cities and countries. So again, just thinking about how while we think about climate change and sustainability, there's a mad rush now to implement some of these models, not necessarily thinking about the environmental impacts they might have. So we come back to what we really think and what we might be discussing today as digital public health. I know we've described different perspectives. This is some of the work that we've done to somewhat consolidate our thoughts about what digital public health might mean. So we think it is the use of digital technologies to transform the delivery of our public health functions in people-centered ways that optimize health outcomes for all. So again, really emphasizing equity as a key piece of the work that we do. We also want to emphasize the transdisciplinarity that it involves. So it brings together expertise in health, technology, and other disciplines that improve the health of populations. But it's also important to acknowledge that we're trying to address modern public health challenges that are amplified through the rapid and widespread uptake of digital technologies. And so thinking about the role that digital public health might play in addressing the digital determinants of health. I'll stop here and invite Stefan to give us first an example of some of the work that he's been doing with the European Public Health Association and the Ministry of Health in Malta. And then we'll take some time to have questions and answer. If you do have questions, you can put them in the chat. I'll be monitoring those to ask during the question and answer session. But thank you. I'll stop here for now.
Thanks, Mui. Just getting up and running with the presentation, which I really look forward to sharing with all of you. There you go. Right. Okay. So what I'm taking a bit of more of a soulful approach, I would like to say, because in order to do really, really good quality digital public health, most of the time you have to breathe it, literally, think about digital public health, maybe not every day, but regularly, to really see how you can really improve your surroundings and the environment that you are living in. And the focus for me is to be more focused on the practice side. Now I'm taking a bit of a different turn. That means I will start with the practical ones first. So sorry about that, Mui. Maybe I messed up the order there, but I want to start with my experience, because after all, digital public health is also about creating your own story. That means what might work in one country might not necessarily work in another one, and vice versa. So there's definitely an opportunity ahead of us to really do things, to really make a difference. Super quick background. Many people have seen this slide multiple times over the years, but I spend most of my time, that would be the bigger circle, in the Ministry for Health and at the university, where I'm lecturing a couple of study units, which I'll tell you a bit about later. And I'm also the vice president of the Digital Health section, as you know. And online, I spend most of my time right now on LinkedIn and Instagram, kind of to try to balance. I barely spend time on Facebook anymore, but most of my time is on those two social networks if you really want to engage with me over there. Now, the first thing I would like to share with you, and something which really struck me as an experience, was the launch of our cross-border healthcare website in Malta, or digital, I would even say digital platform. What happened here? What happened is that there were 4 different initiatives, one of them being treatment abroad, another one being European reference networks, another one being cross-border healthcare unit, and the last one being cross-border e-health services. And before the launch, we decided that on a launch which was focused on rare diseases and cross-border healthcare, we decided, as from an information point of view, to join forces. And thanks to that, we were able to bring all our services, like all one information point for people trying to understand how to experience healthcare across borders, especially from the Malta perspective. And thanks to this, we got some really good feedback, even at the European Commission level, where we had, because in different countries, most of these services are separate. They're not joined together. And this is phase 0 of the project, let's say. It is the information. That is like the low-hanging fruit. You would start from something like this. But now, eventually, we'll be looking at all the different processes that are involved in cross-border healthcare, and we'll try to see how we can apply digital transformation principles in all these different processes. And when you try to bring all of this together, it really enables you to have a public health impact as well. So even though the focus is mostly on clinical care, but providing timely information, providing the relevant information at the person's fingertips enables trust in the system. And when you get trust, you get more trust in health authorities. And when you get more trust in health authorities, you get people trusting more public health measures. So do not underestimate the actions that you take, especially the digital ones, to really bring about change. Because if you bring about trust, then all of us, like in a domino effect, and the same can happen if there is an inadequate experience at another place, which can also affect your experience. So you really need to try your best to deliver a really seamless experience as much as possible. Of course, this is the part that relates to what I work on, which is on cross-border e-health services. I forgot to mention that I happen to be the manager of the National Contact Point on eHealth, where currently I'm managing a direct grant, where we are working on retrieval of e-prescription from other EU countries. Now, this is, once again, this is about primary use. But if you manage a service correctly, then you also enable public health in different aspects. And we're working with a couple of different countries, 6 to 7. And as I will be mentioning later on, I'm also collaborating closely with other European countries, specifically with communication. Now, this is just a part of the website, but of course, the principles of public health were also implemented in some way or another. I know that GDPR is not the best friend of public health, let's say, but because we wanted to do things well, we are working on that to really get the trust of people. And it was easy to implement and as per government of Malta standards. Now, just to give you a bit of an idea of what we're doing, and especially what we're doing when it comes to health data exchanges, this is what we do in Malta, these are the countries on the left where we send health data, and the countries on the right are where we send and receive health data, and we're constantly working on these. Now, even more, when you look at what we're exchanging, we're exchanging two-level documents. We have a level 1 document, which would be the original PDF. Now, luckily enough, in Malta, we have everything in um, uh, in uh, in English, so that makes things much easier. And on the left-hand side, you have the same document, but in an XML, HTML, and in a structured way, which allows for more structured data approaches. Now, I wanted to say as well that as part of our work, working on cross-border health services, we're also happen to work as well on the communication task force. And the communication task force, inevitably, with the work that we're doing, we're also impacting the work which is happening on secondary data, secondary use of data. Because now we're working on rebranding, so to speak, the service for the My Health at EU, or that rather than just rebranding, just rethinking the way we communicate. Intuitively, we're also impacting other sectors and other pieces, like other parts of the cog, so to speak. And this is all because we kind of push, as public health professionals, we push constantly to ensure that there is a high quality. Of course, as you can see, I couldn't resist like messing around and play. And as you can see in the top right corner, we're also having some fun. This was in Vienna about a month and a half ago now. But it's amazing when people who are determined to do the same thing and to improve the service, they come together in one place. Highly recommend it. Now, another, let's say, low-hanging fruit that I worked on, and this is AED Malta. This is a small initiative where basically I had a crowdsourced map of AEDs in Malta and Gozo. Very, very simple. But because you are able to share this information in a very quick and easy way, then you can get people on your side. Now, of course, it doesn't come with hurdles. For example, as I was like developing this and I tried to crowdsource, I also found out that someone actually deleted the data layer. So then I had to rebuild it all over again. And then I learned my lesson the hard way there. But then you also see that because there are initiatives like this, then there are other cascading effects. And one of them being that now the government of Malta actually has a geospatial data infrastructure in place. And that means that this information that is available here, I will, of course, work hard to make this available centrally and manage centrally. So sometimes you have to start with an organic initiative that then translates into a bigger, structured, centralized piece of information, which can help anyone. Now, let's say the launch of the GeoHub, especially from the government of Malta approach, is not might not be beneficiary directly, but it might benefit indirectly by providing a centralized data layer to different endpoints. And because we've been pushing in different ways, then there might be an impact, for example, on the legal infrastructure, which might be used to improve the way, for example, that automated external defibrillators are reported, not just in Malta, but even in other countries. So this is a constantly evolving discussion, and just a simple initiative can really help even improved public health levels in that particular country. So the pushes, the little pushes that you make with simple initiatives such as this might result in a cascading effect which have a positive public health impact. Of course, it's a bit more simple work. Let's say simple, if you want to call it simple. But this is work that we worked on for our seasonal vaccination report. These are activities that were available and showcasing how many vaccinated individuals. But the interesting work that happened with all of this is streamlining the data pipelines behind all of this. And when we launched, the first time we launched the seasonal vaccination report, now it was about 1 or 2 years ago, we first launched with just influenza, and we were able to sort out that data pipeline. Then the following year, we were able to add, this for the last seasonal vaccination, we're able to add even COVID to the equation. And now, hopefully, we'll even be able to add even more vaccinations. and even more like better overall picture. And this is the amazing part about all of this, is that this is a constant evolution. Something like this, a job like this is a result of constantly talking with the relevant stakeholders and constantly evolving. And because of this, then I was able to develop even more detailed analysis, such as a week-by-week comparison, so that we can compare from one year to another, something which was extremely useful and supportive of all the work that we've done. Now, it's important to realize as well that even though this is not necessarily digital public health, but the fact that you push on all fronts to get digital health or digital public health on the agenda, such as what we're seeing with the work that Mui, Laura, Felix, and many others are doing, then you get the opportunity to even improve outcomes. For example, a study unit on digital therapeutics might raise awareness on the need to have a regulatory framework for digital medical devices and digital therapeutics. What does that mean? That means that, for example, that there are better apps, digital health apps on the market. What does that mean? It means increased trust. So all of these initiatives happening and all these different pushes happening on different levels enable even better digital public health. So my recommendation for you, and this is one of the 3 that I work on. I work also on digital health for health professionals, where as of next year, especially, I hope to do a much stronger presence of digital public health in the curriculum, because it will be the year where I will be allowed to do changes to the original curriculum. So I'm really looking forward to this, and I hope it will be the next level. And last but not least, also, this was a course on social media healthcare. Now, each and every experience that you do and evolve, so try to figure out. Sometimes you'll be surprised at the opportunities that are available for you. And as you put yourself out there more, and as you reach out to different people, you have the opportunity to make real big change. And here I want to share a bit my story. Now, I'm sorry if it looks a bit slightly egocentric, because it's like focused on me here. But because of the different opportunities here that I was able to advocate for digital health and health data, then I was able to do an impact on different levels. And I was able to talk to different audiences. I was able to talk to different people. I started creating connections and started building a bit puzzles. But at the end, it all comes down to the fact that you have the opportunity to really make a difference, not only at a population level, but also on the ground. Because I was active on these levels, then I got the opportunity to manage a stand for our National Electronic Health Record. And because of this, when people start seeing this and they start engaging with this material, once again, they give trust. They put trust into these services even more. And because then they put trust into these services, then we are enabling, for example, digital public health interventions to happen on these national electronic health records. And there are, in fact, some new product features that are coming out for my health, which I'm lucky to be a part of, that will enable public health interventions in the coming months and years. And that is because we continue to work on the trust factor. Now, sometimes there are even some very interesting opportunities that happen, which also enable digital public health. And this is, for example, me having the opportunity last week to set up a virtual reality environment for mental health services to promote a mental health support helpline. And I was lucky enough to set up this spatial environment where I was able to showcase something in a very simple way, okay? The advantages of the helpline, the 5 tips to well-being in Maltese and in English. I will share a link to the spatial environment later. But because we bring all of this together, once again, what do? We bring more trust. Now, of course, this didn't happen easily. I've learned a lot of lessons. I'm not going to go through all my COVID experiences. Many of you know them already, but just to mention some, I was also involved in the development of the contact tracing app for Malta It was a wonderful experience with more than 100,000 unique downloads. And it also enabled me to understand the commissioning and decommissioning aspect, like the full cycle. That was a wonderful opportunity. GitHub Open Data, COVID results submission portal, which was backed by legislation, COVID tests, Power BI dashboards, dynamics, customer relationship management, and even the very famous digital passenger locator form, which we had to implement. Of course, there were some, even during COVID, there were some projects that did well and some others which we've learned from and we decided to let go of. And once again, digital publicate is really and truly a constantly evolving process. Okay. And I highly recommend that you work really hard to put yourself out there, because when you put yourself out there, you give the opportunity, first of all, instead of other people speaking about digital publicate, you get the opportunity to speak about digital publicate. But because you have invested in your education as a health professional, I would rather trust you and hear your voice rather than someone else's who might not have put the time and energy to learn about digital publicate. So put yourself out there. And of course, just to show you that just by having a look, you can understand how you're engaging with the audience. So take interest in your digital presence out there. Now, of course, I would really want to mention as well that there are a number of opportunities. So it was important that multiple times I get outside my comfort zone and go to different places and challenge my way of thinking. And something like a summer school, like the one offered by the Leibniz Science Campus of Digital Public Health, this is a wonderful opportunity for you to consider even for this coming summer, possibly. And one thing that was really great is that we even had the opportunity to showcase and tackle a digital public health scenario. In this case, for example, it was monitoring, we're doing work on noise monitoring and enabling reporting in an attractive and let's say trustworthy way. So these are kind of different opportunities. And this took a day or two, and we've done this actually in Canva. So keep a good mind that even though you're doing good digital public health interventions, take the time to go outside your comfort zone and go to a different country. Get yourself out there. Now, just to kind of really cover a bit the actions that are happening from UFA, we're working here in UFA on both digital health, digital public health, and artificial intelligence, I would say. And now we're even having our second iteration of the steering committee coming soon, hopefully. And we now actually have 1,876 section members. By section members, we actually mean, mailing lists, let's say mailing lists subscribers, but many of them, a good amount of them are actually active in our section. So if you're interested and you want to get involved, please do not hesitate to reach out to us as well. Now, we've done a lot of work, and some of the work was also mentioned by Mui, and I believe that now is the time for us to even update our work. So I will work hard to even consider updating the way we look at digital public health, because this is a constantly evolving and maybe possibly even aligning to your way of thinking, Mui. I think there's something that we can really kind of rethink the way we look at all of this, especially with the evolving technology in place. And this was also something that I wanted to share with you as well, not to forget about how digital public health also is constantly evolving. And I really do suggest you have a look at this work as well. And one of the most cited as well is the works that like in the very beginning where we were even looking at digitalization. This was very early on, along with the primary article that I mentioned earlier on. But keep in mind that if you had to go into the basics, that a digital public health intervention addresses at least one essential public health function through digital means. This is actually let's say a definition that I've learned in my digital public health summer school that I attended last summer. And at the end of this, I really would like to advocate for one thing with all of you. Use every bit of your talent and skill relentlessly. You will be surprised how by using a digital technology and combining it with a skill of yours, it might be, for example, learning the guitar and sharing, for example, digital public health principles using music. There's nothing wrong with that. But you use a digital medium to achieve your goals, and at the same time, you tackle possibly an unmet need through something as simple as that. I really highly recommend that if you're interested in this, in working with me, just reach out to the team. A lot of wonderful people here, and I hope that I didn't take too long. Cheers.
Well, thanks, Stefan. I appreciate your time here. We have time for a few questions, about 5 minutes. I wonder if anyone has questions, you can leave it in the Q&A section. You can also put it in the chat. If we'll be happy to look at the questions. I do have questions that have come up so far. One of the questions was around if we had a Venn diagram to describe the intersections between digital public health and digital health, what would that Venn diagram be? I think, Laura, you're speaking to that in a few moments, so I'll leave that up to you. But I know that digital health is sort of the broader, bigger perspective. And what I can say, at least from a Canadian perspective, is that there's been lots of work, especially since COVID, to create digital health strategies. The fear public health practitioners have had over time is that broad view on digital health strategies sort of ignores the potential that digital public health might have as a subsection. So really, especially around thinking through how all of these systems work as an ecosystem to inform public health functions. I know during COVID, there were lots of opportunities to break boundaries and have systems talk to each other, but we're very quickly now moving back into our isolated ways of operating. And that means that there are lots of barriers to connect systems together to effectively make efficient digital public health decisions. So that's something that practitioners are now becoming aware about and trying to raise the need or raise awareness about the need for a digital public health strategy as something that is connected to this broader digital health strategy. I've said too much already. I think Laura will speak to those specifically. I have other questions. I think the first one, someone's asking here, commenting first off, that they are gathering 2 points from the description so far. Digital public health is distinct from digital health. I would like to think so. I would like to think about it as being a distinct but very related field of practice. And we also think that there's lots of intersections that both of them will benefit from. I think Stefan may have mentioned it already, that sometimes it does really begin with some of these digital health interventions, which when implemented well, do one of two things. One, they build trust in digital systems, generally speaking. But in addition to building trust, they then become data gathering mechanisms that can inform upstream decision making when we can aggregate such data. So if we can figure out how the systems are interoperable, then it becomes a very important data source for public health. I think the second point here is that there's a cascading effect between digital public health intervention and other healthcare services. For example, overall perception of healthcare services resulting from well-designed public health services. Yeah, so that's the point. And so this is long, but I'll just try to break it down. These 2 points make me think about the specificity of digital public health in relation to public health. Is digital public health still at its core simply public health, but using a different medium such as digital technologies? Stefan, do you want to speak to that? That's a question, a very interesting and important question.
Let me have a look at it, because I apologize, I was slightly distracted there, but
yeah, so the question is this.
Can you recap a bit the question?
Is digital public health still at its core simply public health but using digital technologies?
Okay, so in reality, if we had to look at this, at the end of the day, our goal really and truly should be that digital public health is simply public health. In what sense? That whatever public health intervention we design, digital needs to be a part of the equation. It can't be left out. So even for us to reach all the audience and to ensure the highest rate of uptake for public health interventions, we simply can't exclude digital interventions. And now it's even coming at the part of the equitable approach as well, because digital interventions are the best way to reach for some audiences. In the same way that we adapted our public health interventions to reach very specific audiences, now the same that we have to do, we have to adapt. And digital public health plays an integral role in this. Now, of course, it's true. Right now, it's really important that we define and make the difference between digital health and digital public health. And I was really struck, Mui, by that table where you had one column for digital health and one column for digital public health. Just looking at that, it really makes me think how I need to rethink the approach that we had towards digital public health in the previous years. So this is something that really needs to play an integral role. There's also a question from Amrita. I'm not sure if we have time to answer it now, Mui. I'm sorry because I really need that.
So we're running out of time, but if you can just briefly answer that question. The rest
Yes, I will
of
answer it in the
the
chat.
question, I'll type answers in the chat.
No, so you want me to answer it now, or should I? I can answer it in the chat. Yeah. So very, very quickly, Amrita. So as such, this is an ongoing project. So I'm learning every day in the project. Right now, we started with testing of the retrieval of a prescription. What that mean? What was the main challenge? That we had to learn different workflow testing, because the prescription had different testing than patient summaries. So that means that I had to reach out to pharmacists to get their feedback and to get them onboarded, as well as testing personnel as well. So constantly learning, and because of this, there's a cascading effect even on ensuring that Mota now becomes fully digitalized when it comes to e-prescriptions, which wasn't the case before. And that means better coverage and better understanding of prescribing behaviors, which means better public health, digital public health.
Yeah. Thanks. I think we've run out of time here. I'll just invite Laura next.
Do you want to start with the interactive activity?
Yeah. Cool. So we'll put in the chat a link to a mural board. And Laura will walk us through the activity if that's okay.
Yeah, okay. Hi, everyone. So that you're not going to fall asleep that much, we also need your brain capacity for the next few minutes. We have created a mural board. If you could all open that one, that would be quite lovely. You can zoom in quite a lot. So the question is, what is digital public health for you? What is digital health for you? If you think of the essential public health functions, which ones are tackled and addressed, in your opinion, by which intervention type? And the question is, what are the resources and the requirements that we need from different perspectives? So I invite you all to zoom in to the very first bubble. And you can see we already prepared some sticky notes for you. And I see the first people already taking those sticky notes. You can move around the board by right-clicking your mouse and keeping it and like holding it while moving it, and you can zoom in through just scrolling. We can either pick an empty sticky note from the pile that we created, or you click on the very left side where you have the sticky note icon and create your own sticky note. So the first question is, what would you consider a digital health intervention? I maybe give you 2 minutes for that one. And there's no wrong answer. Well, hopefully there is no.
What I'm finding useful with the Miro is that you can pinch out on the trackpad and you can use 2 fingers to go from one part of the board to another. I really found it useful. Thanks, Laura.
Okay, we do have some ideas already for what digital health is. So we have sequencing data information, an outbreak location, telehealth, video-enabled telemedicine consultations, online health education, designing health experiences through virtual reality, improving vegetable intake in adolescents using social media. Elida, I see you. Using ChatGPT. Okay, yeah, cool. I invite you all to go to the next bubble, which is like a test to see how well you've listened to what Mui had to say in the beginning. So what do you consider a digital public health intervention? Okay, final sticky notes. So what do we have? So the vegetable intake was actually moved now from digital health to digital public health, like that. We have open data sets portal for public health research, digital vaccine campaigns, knowledge translation resources, providing data online that is accessible to the public, gamification of immunization, serious games to improve attention span in children with ADHD. That is very specific. I like that. And information about infection prevention and control, reminder for cancer screening. So you can see already there seems to be a difference between those interventions. Now let's jump straight to the next bubble, and that might be the one where you actually have to work on most. This is the question of which digital public health functions and which public health functions are actually addressed by what you think a digital public health intervention is. So what you can do is either copy the sticky notes from above and move them to which function you think is the one that is addressed. And keep in mind that multiple public health functions can be addressed by the same intervention type. Or you can even think of a completely new intervention that has not been collected yet and move that to the functions, just so that we can see that maybe there seems to be a lack for some of the functions that we don't have any idea on what the interventions can be. And I've also linked you the resource to the new WHO update on essential public health functions in the document.
So we should move them or we should copy them, so to speak?
I think it's best if you copy them.
Okay.
And then move them to where you think it would fit best. And here's the WHO resource again in the chat. Okay, so there's quite a lot going on in disease prevention and early detection, a bit in emergency management. Okay, let's have a look at that. So we have collecting, providing outbreak data online and freely accessible for emergency management, digital courses and resources for public health workers at the workforce, telehealth for the health service area, open data sets for public health research, access to and utilization of public health and health products for providing online access and using ChatGPT, and then the vaccine, the reminders for disease prevention or early detection. Yes, well done, everybody. Now let's move to the last one, which might be the most challenging one. So assume that you want to implement any digital public health intervention. Just think of the one that comes to your mind. Which requirements are needed from a legal perspective, which would be the top right bubble, from an information communication technology perspective, the top left bubble. What do you need from the social perspective, so from the general public, from the workforce, from the skill perspective? And what do you need from the health system itself in order to implement it, to develop it, and to foster its uptake in the population? ICT means information communication infrastructure and technology. So for instance, Wi-Fi connections, stuff that we don't have in Germany, mobile data. Okay, I give you all 1 more minute. And I will also give you some more sticky notes. Okay. I think what I like most here right now is that you are picturing, without even having further and more details, the same struggle that Mui and I are currently encountering in our latest publication. A lot more legal aspects than ICT aspects that need to be considered. Yes, I will talk a bit more about that in my upcoming presentation, but I could not agree more with all of you, and I want to thank you all for your high participation. This was fun. In case you want to come back to this as a resource, I will not delete this one. So you can always come back to it. You can play with it. You can add more stuff with it. So you can have sort of a living document, so to say, on digital public health. Thank you.
Well, thanks, Laura. And thanks to everyone for participating. It was fun just seeing your cursors move around. At this time, we'll take probably a 2-minute break. If you want to get some water, just relieve yourself a bit. In 2 minutes plus, Laura will come back to describe some of the work she's done to understand from a systems perspective how we can prep public health systems to essentially deliver on digital public health, and what she's learning from both her work in Germany but across the European Public Health Association. Thanks, and we'll see you at 1:12-ish thereabout. Okay, this should a minute for folks to come back on. But if you're here and you're ready, you can just use the reactions icon. If I see a few thumbs up, then we feel like we're ready to go. Okay, I see some thumbs up, so let's go.
Okay, I assume you all see my shared screen.
Yeah, we can see your presenter screen. So if you want to swap it out.
My presenter screen. Okay, as always. So that should work better, right?
Yeah.
Cool. So Mui gave me the challenging task of 15 minutes to present not one but 2 studies, so I will do my very best. So welcome to the systems approach to digital public health. First off, digital public health to me includes digital health, as you can see, and then the figure that Mui already gave as an introduction. So digital public health, as we all know, is a big picture, especially after the little exercise. We all know what is belonging to that, but it also includes the individual and the clinical setting. So Devin, I think if I would put a diagram on what digital public health and digital health are, I would most likely use this one, also because I've developed that one. But yeah, digital public health to me includes the clinical and more individually focusing digital health. So, what are digital public health interventions? I mean, you are now the expert given the beautiful results that you all came up with. Nevertheless, I want to present you a study that was just published last week. So it was we did a scoping review across a number of databases with the goal to map published and existing digital public health interventions. And with that, I can tell you we had to screen 15,000 papers. So we aimed at what are the public health functions that they target? Are there any gaps? Is there anything we are overseeing in the science to practice transfer? So what we came up with as a first result is that the number of publications from the US are high, as was kind of expected. But if you break that down to the number of publications coming from other areas, you can see that Europe is actually leading when it comes to at least the publications on existing interventions. So keep in mind, not all intervention that is out there is published as an article in a peer-reviewed journal. And also the number of publications from high-income countries and the number of interventions developed for high-income countries is also kind of shocking, given that those countries coming from a lower income perspective actually would most likely have a lot more value from those digital tools than the more resource countries would have. So we also had a look at those intervention types. Are they tackling prevention or just healthcare? Are they doing also research? And what is their main target group? So for instance, if you think of telemedicine, at least for us in Germany, most of my public health colleagues do not assume that telemedicine is public health, given that it is only focusing, presumably, primary or secondary healthcare and ill people. However, looking at all of those people here, looking at all of those publications, you can also see that telemedicine is also tackling prevention areas. So we can actually do health promotion and then primary prevention interventions through telemedicine. The same was identified with health records. Yes, usually those people that are chronically ill or are health professionals will value electronic health records most likely more than the healthy people without any risk factors. However, you can also see them. And you can see how health records are used for prevention and health promotion purposes as well. So does that mean that we have to get away with the understanding and the assumption that specific interventions are only focusing on one specific area? And can we actually still say electronic health records are interventions that are blah? Or should we rather say an intervention having this setting and that target group is what we're looking for? Coming back to our dearest public health functions. This is the old public health functions by the WHO, because the new update was not published by then. But this is all the overview of all the interventions that we had a look at. So all of those included interventions are listed here, and we grouped them for their digital health functions, which is the rows, and the essential public health functions that they address, which are the columns. And unsurprisingly, the majority of them tackles healthcare. We also see some interventions working on public health emergencies, and Felix will tell you a lot more about that. We also saw some interventions on financing and some for research, but we also see a lack, especially when it comes to preventive behavior change and in governance, no intervention. And we also see a lack when it comes to health promotion and calculating health promotion advantages, for instance. This is now the overview for only the telemedical interventions. Unsurprisingly, the majority of them was tackling healthcare. And this is the overview for electronic health records. So now coming back to my previous question, do those interventions actually differ? I would say yes. You do not have to read through all of that table, but this is a qualitative analysis that we did just for telemedical interventions to see the number of references and what they're describing as a technological function and feature that those interventions have. So you can see, depending on what your features are, your intervention might completely differ from another telemedical intervention. So I would argue that these interventions are diverse and that we should be very careful when we say, hey, country A, do you have a telemedical intervention? Do you have electronic health records? Because what you might understand from those intervention types might be completely different to what your colleagues from around the globe say about that. So instead of asking, hey, do you have electronic health records? You should ask for, hey, do you have an intervention with these features and that setting, targeting this and that population groups? Building on that, I did a multinational Delphi study, which was also just published a month or so ago, to measure the maturity degrees. So we also asked, what are digital public health functions and tools for you? And what are the maturity levels? So from the legal perspective, the ICT perspective, from the healthcare perspective, and the social perspective, just as you just did. We had roughly 45 people that participated in at least each round, although 82 sign up. So if you are doing a Delphi study, make sure to always invite more people than you will need in the end, because a high number of them will drop out. And you can also see that this was a very vast field. So people coming from 17 academic domains and from 27 countries. That was quite cool. Obviously, being situated in Germany, my network in Germany was the broadest, so people from Germany were always the most. But for each round, we had contributions from every continent, which was quite nice. And eventually they came up with 25 different tools that are defined as digital public health tools from their perspective. So they said digital public health is a public good, which means for you as a user, it needs to be free. That means the insurer or the regulator, the government will pay for you being able to use it, which is, for instance, why those dearest wearable devices that most of us have and that are typically assumed as digital public health in Germany were not seen as digital public health by our users. Because in most countries, you have to buy them for yourself and on your own without being reimbursed, at least in most countries. So they said this is not digital public health. The other thing that we found was that those interventions focus on secondary and tertiary prevention as well as healthcare, which was again quite unsurprising given the previous study that we did with the scoping review. So what they are not is the digital twins, which are quite broad right now in discussions. They're not sensors, they're not wearables, no smart care homes, no social media chats with your health professionals, no electronic health insurance cards. Those were all seen as digital health. Now coming to the fun part, we asked them, okay, and how can we actually measure the maturity of our health system? They came up with 96 indicators. And here you can just see the broad categories, because I think bombing you with 96 indicators would not do you very well. So please use the link to see the whole list of all the indicators. When I checked for those indicators, whether or not they've been already covered by the broader literature, I saw that not only 50% were covered, which is also the reason, mostly because indicators are published for digital health, but not for digital public health. And digital public health indicators actually need different topics than digital health indicators. And what we also found was that if you have a look at the ratio and which indicators are covered, we also saw a very varying degrees of coverage, which is most likely due to also different approaches when it comes to methodology. So people from the social science rarely use indicators. Instead, they prefer to use representative surveys. But you can't really do that if you want to do a maturity measurement and assessment for your country. You can't really ask your population all the year. But on the other hand, for the information communication technology area, there were lots of indicators that are covered already because they are most likely very easy to collect and to assess. So also keep that in mind when you want to do assessments like that. So what have we learned? Those digital public health systems and maturity systems you cannot conduct as a public health expert on your own. You also always need to have colleagues coming in and supporting you from other perspectives and from other disciplines and with other backgrounds. We require new indicators compared to digital health maturity measurements, and not all indicators are applicable for every setting. As Stefan already said, you have to consider that not everything fits always. So the next step that I will do for the next future and for the next research will be to have a look at all those indicators and to build a tool actually that we can use to measure the maturity, to make the most out of those 5 currently more theoretical pillars of digitalizing your health system. So you have the analog level on the very bottom, which is hopefully a state that both Canada and Germany and Malta have exceeded already. And then you can move up the ladder to the innovative and to the value-driven health system that has fundamentally changed and is adapting to user needs and to changing user needs especially. So that's it from my side, and for the record, here are the literature. Thank you.
Well, thank you, Laura. Thanks for. I wonder if we have access to the slides. I'm interested in reading it a little more. But coming next, I think this is where we sort of ground ourselves. We've sort of had many conversations about what we can do with technology and how we can prep systems to use technology. But like we've talked about, digital transformation is occurring more broadly within society. How can public health be more better positioned to respond to that? So I'm excited to hear from Elida, to see some of her work around tracking some of the broader implications for digital transformation, especially among children and adolescents.
Yes, good evening from Germany and good day in Canada. Thank you so much for the invitation to present some of my work today. I hope you can hear me well. Hopefully I won't have internet connection problems. So today I will be speaking about the other side of the coin of digital transformations, and I will share with you some of the work I have been doing during the last years, focusing in children and adolescents, and how growing up in a digital environment influences their health outcomes and health-related behaviors. So as we all know, for that generation of ours where we used to play the snake game in our dad's Nokia phones, we know that the digital environment has changed dramatically during the last 10-15 years and is now much more colorful, interactive. Kids today can use a smartphone, a tablet, internet, of course, ChatGPT even today. And that means that this digital media environment not only offers opportunities for education and for maintaining or creating social relationships, which are very important for youth, but with opportunities come also risks, because these digital tools today, including the social media, can also lead to addiction, can lead to multitasking, and also to they also represent a new environment that up to now it's not fully regulated, and is also a golden area for companies to make advertisements. And as we spoke about at the beginning of this session, that today we are the greatest minds are actually thinking how to make us click ads. So today I also want to share some of the studies that we have been conducting here in Bremen, and by the end of this presentation I would like to make you think that yes, digital technologies are awesome and they are very helpful for healthcare and public health, but we also need to be cautious when it comes to, especially to youth, to vulnerable groups such as children and adolescents. And today I will walk you through my work, where we have investigated that digital media is a potential determinant of health, especially of metabolic health and mental health, where we have worked for metabolic syndrome and cognitive functioning, but also on health-related behaviors such as food intake and eating habits. And the first question that we investigated was, how does social media exposure influences children's and adolescents' diets? And to answer this question, we used a systematic review approach in order to also understand what are the underlying mechanisms of this potential influence of social media on children's diets. And in our systematic review, we included 35 studies conducted worldwide. A majority of them were randomized controlled trials. One was a 2-year longitudinal study, and 11 were cross-sectional studies. The studies showed that social media exposure is associated in a dose-response manner with a daily intake of sugar, caffeine, and unhealthy snacks. Moreover, social media exposure is associated with a higher consumption frequency of sugar-sweetened beverages and with a higher likelihood of skipping breakfast, and with a lower consumption frequency of fruits and vegetables independent of children's age. But what are the mechanisms, the underlying mechanisms that of how social media influences food intake in children and adolescents? We observed that the main mechanism is what we call the neurophysiological mechanism, and this was observed in randomized controlled trials using fMRI methods, where children were exposed to unhealthy food images or to healthy food images. And it was observed that when children were exposed to unhealthy food images, they showed a higher brain activation in areas that are related with reward, attention, memory, and decision-making, as compared with healthy food images. There were three factors that impacted this brain activation. First, the energy density of food that was depicted in these images. Second, the portion size of the food depicted. So the higher the energy density and the higher the portion size of the food depicted in these digital images, the higher the brain activation in the areas related with reward and attention. And the third factor was also children's appetitive state. So children who were in a hungry state and viewed these unhealthy food images, they also showed a higher brain activation in the mentioned areas as compared to children who were in a satiated state. The second mechanism is what we call the social mechanism. And here, the social media influencers come into play, which are all over social media today. And it was observed that social media influencers advertising of unhealthy foods led to an increased intake of the advertised unhealthy foods at ad libitum, and this was independent of using an advertising disclosure or not. So for instance, hashtag paid partnership or hashtag advertisement as shown in this screenshot. Interestingly, when the same social media influencers were advertising healthy foods, this did not affect healthy food intake at ad libitum. Next, we wanted to understand how does digital media exposure influences children's cognitive functioning. And to answer this question, we use data from the Ida-Fixi family cohort. So it's an observational research and not a systematic review. The Ida-Fixi family cohort is a pan-European cohort of including children from the age of 2 up to 24. Living in 8 different European countries. And for this particular study, we use data from wave 3 of the cohort. This is a cross-sectional analysis nested in this cohort. In terms of digital media exposure, we used self-reports on different media, including smartphones and internet, but we also used information on media multitasking, which was defined as using computers simultaneously with other media. Measures of cognitive functioning included the emotion-driven impulsiveness. So how do children and adolescents react towards negative emotions, which was self-reported. And then we used computerized tests to assess cognitive inflexibility and decision-making ability in the participating children and adolescents. Our results show that daily smartphone exposure was associated with a higher impulsivity and cognitive inflexibility score and with a lower decision-making ability score, independent of a number of confounders. Moreover, engaging in media multitasking was also associated with a higher impulsivity and cognitive inflexibility score and with a lower decision-making ability score. Interestingly, these associations were more pronounced in participants from one-parent families as compared to two-parent families. Next, we wanted to understand whether using digital media does have an impact in the long term on the risk of developing metabolic syndrome. Again, we used data from the Ida-Fixi family cohort, and we conducted a longitudinal analysis in children aged 2 to 16 years. I will not give a lot of details here. I just want to emphasize that we used objectively measured data on metabolic syndrome and its components, so including abdominal obesity, blood pressure, dyslipidemia, and hyperglycemia. And we calculated Z-scores for each of these components. We also identified children who were at a monitoring level for metabolic syndrome if at least 3 of the 4 components excluded the 90th percentile of the scores. with regard to the exposure. So we used self-reported data again on digital media exposure, and we calculated the age-dependent trajectories of digital media use from the age of 2 to 16 years. And now I will show you a little bit of how this looks like. So we calculated the trajectories for the overall population, but also by sex. And we observed that digital media exposure increased as children grew older. So from 2.4 hours per day at the age of 2 years to 5.5 hours per day at 16 years. So this is quite a high increase. As you can see from this graph, boys showed a steeper increase compared to girls over their development. Next, we observed we investigated whether these increasing digital media trajectories do have an impact on the risk of developing metabolic syndrome later in life. And we observed that digital media trajectories, so both in the terms of intercept and slope, were positively associated with a metabolic syndrome score and its components in the long term, independent of physical activity, so moderate to vigorous physical activity, but also independent of sedentary time, which were both objectively measured as well. Then we observed that those children who had an above average change in digital media exposure during childhood, they showed a 22% higher risk for metabolic syndrome. And this risk was higher for boys, 41%, compared to girls, 10%. And this risk was also higher in children who were living in countries such as Cyprus and Sweden, who also showed the steepest digital media trajectory. So to conclude and to summarize, our work during the last years has shown that digital media exposure has a potentially unfavorable role on children's metabolic health, cognitive functioning, and food intake. We were able to identify subgroups of children who are most vulnerable to this potential negative role of this digital environment, such as boys for metabolic health and children from one-parent families regarding cognitive functioning. What about public health implications? I think, given that our data is based on cross-sectional and longitudinal data, however, we need to take a precautionary and a children's right approach to health to protect children in this digital environment by two main strategies. First, by downregulating unhealthy food marketing on social media, as was also supported by the results of our systematic review, but also by increasing their media literacy or their advertising literacy. And here we can give the examples of understanding how the algorithms work on social media, or how do the dark patterns work on social media that keep us hooked in these sometimes toxic environments. So that's it by my side. Thank you so much for your attention. Sorry if I took longer. It was a lot of information, but I'm happy to take your questions.
Well, thank you so much, Elida. Every time I've seen this presentation, I've always, well, one, been excited, but also really concerned as a young father myself. It's like, what do we do about the iPads and stuff for my child? Are there any questions that you want to ask? I'm encouraging you to use the Q&A function. If you want to talk, you can raise your hand and we'll be happy to invite you. But in the interim, I do have questions. Elida, you talked a lot about the impacts that influencers were having on dietary patterns, and how promoting positive eating didn't necessarily result in good outcomes as compared to, high or calorie-rich foods. And my question is for some of us who are here in the role of health promoters, and how we constantly press our organizations to give us the license to engage through social media to promote some more positive eating as a way to counteract some of the negative things we see online. And I'm wondering, is that futile given some of the findings you're exploring?
Yes, we were also a little bit disappointed to see that when social media influencers promote healthy foods, this doesn't necessarily improve food intake. And that can be explained by the fact that the intervention that was conducted included only, for instance, banana advertising or peppers. But when it comes to fruit or vegetable intake, I think, and especially with younger children, it's a bit more complicated, and it needs to include a variety of foods, probably, as given that they are also picky eaters, some of them, but also the way the intervention was delivered was by measuring only ad libitum intake. And maybe that means that when we want to deliver digital public health interventions using social media and using social media influencers, then we also need to think about a longer time, maybe using at least 2 time points in order to understand whether this has an improvement over time or not. Yeah, it's another explanation is also that here they were only 3 randomized control trials included, and but we actually need more work in this area to understand why social media influences don't necessarily help children to improve their fruit or vegetable intake.
It does bring into question whether, and I wonder what the interventions look like, but whether we need to first off learn to be more creative around healthy food promotion online. Whether it's, for example, there are a few influencers I follow who creates nicer ways of using healthy ingredients in food. I don't know whether that's effective. I'm just, as a layperson, speaking here.
Actually, yes, that does also have an effect on how food is plated, or how it is combined with other ingredients. Yes, that has shown to also impact our brain activation. So fMRI studies have shown that the better or the nicer the food is plated, the highest is our brain activation in areas related with reward. But this is mainly in adults. So there are no studies that show whether a better visualization of food while delivering interventions can help to increase vegetable intake, for instance.
Yeah. I have more questions. There's quite a few questions. I'll try to go through them as much as I can. On the subject of food, I think for Canada, food inflation is a big topic. And the question here is, do you know if there's a shift generally away from healthy eating due to inflation? And has there been a concurrent increase in unhealthy foods then being seen on social media alongside that food inflation? I guess this topic really, or this question really, speaks to the interaction between the commercial, social, and ecological determinants of health with the digital determinants of health, and how all of these forces are combined now to become a sort of perfect storm in determining health outcomes for people.
That's a very good question, actually. And I think especially after COVID, our attitude towards food and the economic crisis, the energy crisis, all of it has impacted how what foods we buy. But honestly, I do not have in mind right now whether this impact is still ongoing after 4 years now. but I think that's something I will need to look at and maybe get back to you and share articles on it.
Well, thanks for that. The next question sort of gets at some of the points, Laura, you've been trying to raise, and some of the things we've engaged more personally around understanding digital public health maturity. So yeah, this presentation brings to mind Audre Lorde's question of whether the master's tools can actually dismantle the master's house. Thinking about the role of social media and all of the other technologies are playing in current society's fabric. But the question then is, how can we more effectively regulate these systems within the larger capitalist ecosystem? And what have you been finding in terms of what legal systems need to be in place to adequately address some of these risks?
That is a tough question. Thank you for that one. I know that people in Brazil are a lot better, most likely, to explain that than I would be, because they have been struggling with those capitalist and most likely also corrupt developers much more than we have in Europe, given our quite narrow regulative system. So I think we can totally get rid of the idea of getting those people and those companies out of the market. We will not be able to do that. So we have to find a way of developing interventions either together with them or to create an environment from a regulative perspective that limits those toxic behaviors and dark pattern approaches that Elida talked about. However, that might also be a challenge, given lobbying is quite a thing all over the world. And unfortunately, those companies have a bigger lobby than us public health people. We might all need to change our attitude towards that and unite so that we also have a bigger voice and be heard. So what always needs to be done is to improve literacy, not only the digital literacy and the health literacy, but also, as Elida said, the advertisement literacy, the social media literacy, and all stuff like that to enable people so that they are capable of seeing the good and not calling it the evil, but well, the good, the helpful things, and the ones that are helpful to you losing money, so that they can decide which pathway they want to go. What we have seen, for instance, during the pandemic was that people are very happy to share their personal data on social media and on Facebook and everything, but were very hesitant when it came to downloading contact tracing apps developed by governments. And so that is also a social thing and a social attitude that we have to address. It is something that you cannot address through regulation and through force. But it is, as Stefan said, that has to be dealt with trust. And if we can foster trust of the population in those interventions and in us as experts, then I think we are a good step, not ahead, but at least a bit closer to those big companies.
It does bring a question to mind. So some of the work we've been doing here will suggest that regulatory environment really lags behind the speed of development and scale of development of some of these digital tools. And I wonder whether one of the problems here is just one about capacity for public health practitioners to, for example, preempt potential impacts that some of these tools might have, and more actively engage in the policy framework creation process to ensure that we protect the health of especially the most vulnerable people within society, and advocate for both access but safe access to some of these technologies. There's lots to say in this context, but we'll take a break now for about 5 minutes. When we come back, we'll be doing a group activity where we want to just reflect with each one of you about what you've learned so far, whether or not this has sort of changed how you view the term digital public health, and what practical learnings you might be taking from some of these conversations going forward. Like I said, this is the first of a number of sessions, and this first session is more conceptual. And hopefully in the next few sessions, you have more activities that are, hands-on. But let's take 5 minutes will take us to 1:58, and then we'll be back to have conversations in the groups. Swathi, who's already organized, will send you directly into groups, so you don't have to worry about joining a group. Thanks, and see you in 5 minutes. Okay, so it's 1:58. I see a few folks have dropped out, but those who are still here, if it's okay, we'll send you into the groups. I assume a few people will join in as they come back on their breaks. So Swati, would you be okay getting folks back into the groups if they do come back in? All right, so yeah, I think we can do. Okay. Sessions or how to time these things. But yeah, it I guess in the rooms we all talked about having someone summarize if within the groups, and we can go group by group. If someone is able to volunteer to just summarize the conversations there, it would be great. In my group, I will try to start. I was in group 1, and I had interesting conversations with Amrita. We talked about digital transformation, but specifically within the health system, because we think that that's one that's really important. The public now has demands for a more digital, a digital way of serving public health functions. And so the question is, how can we better support these needs? One of the things that we talked about there is that there are potentially challenges around usability of the systems, even though people need the systems are not necessarily usable, both for health providers and for citizens who need the services. And so we need to be strengthening competency first for public health functions, strengthening competency so that people understand existing policies that are needed to deliver these digital public health services, and then thinking about how we can more effectively support people. Obviously, there will be cost implications to doing that, but effectively support them to engage with the systems and deliver public health functions through the systems. I think in group 2 we had a few folks. I wonder what those conversations were like.
Hi, it's Devin. I think, oops, sorry, actually, Trisha, I'm sorry. I kind of dove in. Do you want to summarize?
No, go ahead. I took some notes as well. I just turned my camera on DiPH.
Oh, you're able to turn your camera on. I'm not. Why don't you go ahead?
Okay. I'm not sure if we all had the same questions, but our discussion around what potential issues can you think about given the widespread adoption of digital technologies in society, we talked about the digital divide and how as we increase implementation of new solutions or digital and virtual health solutions, we just greater increase that divide, and then that impacts the access and the equity, specifically in rural populations, and just the impact of implementing virtual health solutions when there isn't any access in those rural communities. We also talked about the importance of co-design in perhaps tailoring education. When we were talking about education and how it would be important to identify the gaps that we're seeing when we're implementing digital technology, and we noted that co-design was a really important or key aspect. So co-designing with the community leaders that you're tailoring the education to. So for example, co-designing with, if we're tailoring education to newcomers, co-designing with a newcomer leader, and just paying attention to how we meet the unique needs of that population and just that sort of level of awareness. That's all I had in my notes. Felix, Devin, did I miss anything?
No, I think it was a nice high-level summary.
Yeah, I guess the one thing I would throw in is I think what also led to our discussion around the importance of education and tailored education was we talked a bit about the spread of So digital technologies influencing the spread of mis and disinformation, and then those downstream impacts on public health. So like one example would be just the lack of or increasing resistance to vaccines, and now the increasing rates of measles. And then also the impacts of like social media in general on health promotion. And so like, how do you respond to that? And one of the things that we'd also talked about is just actually understanding what those impacts are, which may be on a more of a research side, but I think certainly within the BC Centre for Disease Control, there's not a lot of discussion about that. And so we need to understand what the issues are before we can respond to them.
Fantastic conversations. I'll move on to group 3.
So I was in group 3. We talked a lot about this increasing evidence about the negative effects, particularly of social media on children's development and on people's mental health. So we discussed maybe about some interesting relationships there and how social media are in this paradox of isolating people, and the challenges that we have in that as public health practitioners in how to intervene in that situation, because we talked a bit about how restrictions by themselves and to the end users of that might not be the best strategy to act on. So we discussed a bit about regulating corporations and algorithms, and also focusing on digital literacy for people to make their choices when facing these platforms. I don't know if I missed anything.
No, you summarized it very well. Only one point that I think was suggested by Sonia, and I really loved it, was that governments and local agencies need to work with young parents. So by providing what she called prenatal education on how to manage digital hygiene, especially by not exposing young kids at the age of 6 months to YouTube while you try to introduce them solid foods. So I think this is a very important point that was mentioned, and maybe can be really helpful, but we will see.
Yeah, I think that's a very important point. I think in BC, for example, there's a program called Lead 5210 that does similar work along those lines, trying to educate young parents and communities on digital hygiene alongside other healthy habits, including diets, outdoor play, and so on and so forth. I would invite group 4 to speak. I think that's the last group.
I think we were group 4. Okay, good. I didn't pay attention to the breakout room number. So I have some notes here. So for the talking about the potential issues, we were talking about how the digital interventions are still developed at an individual level, rather than have it as, and the literacy as well is still a choice rather than like a structurally shaped concept. We should all be able to access and use these interventions. Similarly, health promotion is still sort of up to the individual instead of having sort of more of a regulated form of health promotion. Also talked about that there's misinformation, not only in social media, but also in how to understand and interpret health data that we're given. And very much there's different levels of trust towards different organizations. that's a challenge. And then in terms of how public health is responding to these issues, some of the things we've seen is that there's public health campaigns to combat misinformation, and that these are even occurring on, social media platforms, things like that, for example, to try to target misinformations on vaccines. And also that the public health should move more away from the individually focused interventions towards more population-based interventions, with the extent where it's building public health that's aiming to build these new landscapes. And then in terms of competencies that are needed, one of the things is having sort of leaders that are enabling these environments to help with digital health competency and literacy, and seeing the larger environment, not just looking at specific groups, but looking sort of being more visionary and social leaders, and also having more information and education on how to navigate across different data sets and how to look for and find data. As a lot of the times now, that sort of literacy is just specific to social media instead of just finding different websites across the internet. And then also, targeting this to people with different levels of digital literacies, and especially targeting sort of younger people who are going to be growing up and needing to use the digital public health more day to day.
Well, thank you, everyone. I know it's been a very long day, and thank you for taking the time to summarize some of the conversations. At this time, I'll invite Felix to give one final example of the use of digital technologies for public health functions. Specifically here, we're looking at public health functions in public health emergencies and disaster response. Thanks, Felix.
Perfect, thanks. So hopefully I'm not going to cut out, because for some reason my internet connection decided that it's way past its bedtime. But I think I managed to fix it, or hopefully fix it during the last breakout. Can you quickly assign me as the host, because I also dropped out once and I'm not allowed to share my screen right now. That works, perfect, thank you. All right, can you guys see the slides? Quick hands up, perfect. So yes, so we're going to change gears quite a little bit, and I'll just give you a very different example of a public health response. I'm not really going to focus too much on the preparedness aspect, just because 15 minutes is very short. I'll make some remarks, but I'll mostly talk about disaster response and how digital technologies have played are playing an increasingly important role in this. I'll start with some more historical examples, but then obviously talk about the current ongoing Gaza response, and also kind of highlight challenges with digital tools, because there's a lot of blockages of internet connections, for example. So just to bring everyone on the same page of what international medical emergencies are, if I had done this presentation like 3 years ago, it would have all been about natural disasters, but unfortunately the new reality is also that armed conflicts are a much larger issue again, unfortunately. So we'll talk about other emergencies as well. But a typical example of an international emergency is, for example, an earthquake, which do happen quite often. They lead to initial destruction of housing infrastructures. They lead to initial injuries that need to be treated, but also they lead to a lot of destruction of infrastructure, both directly related to the healthcare infrastructures, so hospitals and doctor's offices are just gone, but also obviously to other infrastructures such as water and sanitation infrastructure, which then have devastating health effects. So for example, here you can see an image after an earthquake, that a hospital can either be damaged by an earthquake, or in this case, it was damaged by arms. Other examples, which is very recent, are quite large-scale floodings. Floodings are particularly bad because they can also introduce a lot of waterborne diseases quite quickly if there's larger bodies of waters that are usually not there. And then obviously what everyone's aware of right now, this massive international disaster response that we see in the Gaza Strip. So you can, again, see a lot of direct destruction to houses and living infrastructure, but also, which I think probably most of you have seen, this image of hospitals being either damaged or, in this case, for example, the Al-Shifa hospital just being fully non-functional anymore. And to respond to this, the international community is quite active, and they tend to send teams to support this. They've always done that. And the turning point of when these international responses had to be regulated was in 2010, because there was a big earthquake in Haiti. Given the close proximity, especially to the States, led to a lot of not really qualified teams providing care. There was a lot of like highly sophisticated work and support that I'll show on the next slide, but it, for example, also led to a lot of faith-based organizations traveling to Haiti, and they often had more Bibles in their luggage than actual medications. So after that response, the World Health Organization kind of analyzed the response and saw that a lot of those teams did very good work and were able to save a lot of lives. But there was, first of all, very little data about what work was actually done, and especially very little data about those teams that were not competent and kind of were practicing way out of their scopes. And as a result of that, they established what is now called the EMT initiative, so the Emergency Medical Teams Initiative, with the idea to set minimum standards that teams that are providing care need to fulfill, that they have to be classified, that they have to be certified, but also as part of this initiative, they set out, but they installed a coordinating mechanism and a big reporting mechanism, so that there's a set number of data that we get from each of those teams on a daily basis, both to monitor their quality of care, to monitor the patient's loads they see, but also especially to be able to do a lot of public health surveillance. So you can, first of all, kind of see the patient demographics. You can know if patients were, if the treatment was directly related to disaster or not. You can monitor potential outbreak situations. But that kind of turned into something pretty massive for a disaster setting, where your response would look like something like this. So this is a picture from the 2010 German Red Cross Hospital that was set up in a soccer stadium in Haiti. And it's basically kind of like your county level hospital quality that's offered here, but it's all based in tents. You'll bring a water and sanitation station with you, you bring your generators with you. So you kind of wouldn't really expect a lot of computers or digital tools here to begin with. And for the longest part, most of the documentation in those facilities was done paper-based, but now we do see a lot of digital tools. And one of the nice examples was from about a year ago in March, after the earthquake in Turkey, where there's a lot of nice data available about overall high-level aggregate data showing the response. So you can see the affected areas, and you can see the different teams and their classification status of kind of the care that they're providing. And then this is kind of even on a public-facing website, so the broad population was able to access these data. And then behind this, there's a lot more data with GIS tools and the daily reporting tools that you can then really see use to kind of monitor the response and also do a lot of public health surveillance work with it. But to get to this stage, it's kind of a long process. So let's quickly look at the current state of documentation first in maybe Western country EMS and hospitals. A lot of that stuff is now digital, and I'll talk about the reasons why it's digital in just a minute. But in those EMTs, for the longest time, it was paper-based, just because you couldn't be bothered to bring all the electronic devices for electronic documentation with you, because you're struggling to set up your tents, you're struggling to provide care. So electronic documentation wasn't really a thing. It slowly started by having small network, by having printers, by having a laptop or two just to do some admin work, but medical documentation was predominantly done on papers, and it still is to this day, but it's now very quickly changing. And that is mostly due to the fact that those reporting requirements have been introduced by the EMT initiative, kind of following two goals. First of all, monitoring the quality of care, but then also for the coordination and for public health purposes. And that minimum data set that was developed needs to be submitted by any medical team that's operational. The idea is that it's kind of good enough information, that it's not super detailed, and it really has a focus on kind of the acute phase of an emergency response. I'll share some of the insights of why that's kind of problematic and is not really applicable anymore. in just a second, but even to get this good enough overview, it's already 50 indicators that each of these teams need to submit to the coordinating body on a daily basis. And the submission form kind of looks like this. So every team submits it. It contains some static information like team information, location, contact details of the team lead and whatnot. But then there's a lot of stuff that needs to be updated on a daily basis. So you have some high-level summary stats that just shows the number of outpatients, new admissions, live births, your bed capacity, empty beds, and occupied beds. And then it's a breakdown of the actual MDS statistics. So it's a set of, I think it's 31 diagnoses that you need to fill in. There's some needs and risk assessments that you can fill in, but the bulk of the work is really about those MDS statistics, because that's a kind of the key piece of information that the coordination cell is using both to monitor response and especially to the public health surveillance. And the idea when they initially came up with this is that on each of your your paper-based documentation, you would have those tick boxes with those different indicators that you need to report on that would then be fed into a reporting form. And that might work out okay if you see 10 or 20 patients, but if you see 200 or 500 patients, it's a boatload of work to do that every night to compile that aggregated report. And a colleague of mine who did it in the last earthquake in Haiti, it always took about 2 hours and 2 beers each night to actually do this report. So an example of how this would look is that a clinician would ideally fill in those boxes, which unfortunately is often not done, so it's incomplete. So you either need to go back and actually fill it in, or it's just going to have a lot of missing data. And if we look at the indicators that are reported here, you can already see that there's a lot of focus on public health in emergency settings. So for example, you really want to know if you see a spike in cases of acute water diarrhea, because that will then give you a hint that there's a water and sanitation issue that you need to quickly tackle before it becomes an outbreak, for example. So having this data on a patient level, aggregated to a facility level, aggregated to an overall response is key for you to be able to react quickly. So you have your list of, so to do this paper-based, you would have a list of all the patient files, you'll then have a tally sheet, and then it would take you a long ass time to actually put this into a final report. And just to kind of quickly show what is done with that report is that it's shared by the medical teams with this coordinating mechanism who kind of reviews it in a lot of detail, but then also shares it with others. For example, it's shared with the Ministry of Health in the country that we work in, it's shared with the WHO headquarters, and it's shared with like other stakeholders that need to at least see a high-level summary of it. So it's in my point of view, it's a really nice and very agile mechanism that will give you a lot of up-to-date data. You can then quite quickly react to it, kind of change the services some of your teams offer, or even just start public health interventions if you see a spike in cases. But to have the data is just quite challenging. So that's why even in these settings, digital transformation is now happening quite quickly. And as I alluded to earlier, documentation in German hospitals, for example, is already digitalized because there's other drivers that are in place. The biggest one that we see in high-income countries is financial incentives. So for example, the need for good medical documentation for billing purposes is there. Like for example, in the German EMS system, the main driver for digitalization is legal requirements. There's a ton of reporting that needs to be done that can now only be done in a digital form. Sometimes staff and resource shortages can be a driver. So for example, for telemedicine, and then maybe a minor driver in an ideal world is also improving patient safety. And in this case, it's kind of a little bit of both, of legal requirements and staff shortages, but mostly legal requirement, because these teams need to do digital documentation to actually fulfill the legal requirement of daily reporting. And it can save some of the staff shortages, and a nice additional driver is that we do improve patient safety on an individual level while having a digital tool that will help with the coordination. And just to kind of show what this could look like in an ideal world, so instead of having the tally sheets on a piece of paper, we now have a tab for the project that I'm working on. The Red Cross now has a tablet-based documentation system for their field hospitals that can be used for patient-level documentation. It can be used to kind of facilitate the data flow in your hospital, because it also has request forms for lab tests. It has functionalities for requesting other tests and services and for documentation, but mostly it really streamlines the reporting. So we have all the indicators that we need to report in this tool. And then basically by the click of a button, you can then create that summary statistic. As you can see here, we're selecting the day for the report. And then it's preview, and then you're done. So instead of it taking about 2 hours for like a regular sized field hospital, it's about a minute, which is a big step. And a lot of teams are currently working on looking at building those tools, but none of them are actually functional right now. So it's really at that really interesting step where things are happening quickly, but haven't really happened yet. And this is kind of the outcome at the end. Let me now quickly jump to some of the kind of like what it looks like right now. So this is a picture of the response that was done in Moldova. And I was in the coordinating mechanism in Moldova as part of the Ukraine war. And even though in an ideal setting, you would have that niche dashboard, that was the main piece of paper that was used both to monitor the teams available, the teams that had already left the field again, kind of monitor the departure dates, monitor the different services that we're able to offer. Even though I was like the fourth coordinator to take over the coordination of those teams, this was still the main piece of paper that was used for the coordination. And the next one over would have been the kind of the monitoring of outbreaks. So it's really crazy to see that this is still the tool that is used, even though we already have those drivers to actually get to digital tools. And just to quickly show able to use digital documentation in any setting except maybe an armed conflict like Gaza. So we did some pilot testing with our tool in Portugal, and they, for example, use Starlink at big festivals, and then their disaster response. So internet connection is not an issue. So you bring your devices, they have a battery, you bring your Starlink, you have a perfect internet connection. It's probably faster and more stable than what I have right now. So that all worked quite well. But now, just in the last maybe minute that I have, and I'll maybe steal a bit more of your guys' time, in the Gaza conflict, that's unfortunately quite different. Because the one thing that we need for all this reporting to be done is a stable internet connection to share the data, at least on a daily basis. And especially in an unsafe environment, the coordinating body will not sit in the conflict zone. So for example, the Gaza response, that coordinating body that coordinates the teams, that makes sure that tries to allocate the resources as best as possible and also is monitoring the health needs, sits in Cairo. So they need to get this data on a daily basis with an internet connection. So this is a picture of the brand new Red Cross hospital that was set up just outside of Rafah 2 weeks ago. And that one sits on a beautiful location, but does not have internet right now. In the beginning, it had internet for the first 2 days, and now it's just cut off. So we're currently working on a fully offline setup. Right now, they're documenting paper-based, but a documentation system is supposed to be introduced here in about 2 weeks' time. Oh, 2 months. 2 months. But the main issue is really getting that electronic data from your hospital to the coordination body. But so far, and I'll show you some screenshots, there's actually a public-facing website. So if you are keen to see this, you can just Google that website and you'll see some high-level statistics. But the main issue is here, the data is quite incomplete. So they have set up the tools and try to coordinate it. This first one is pretty correct because it's just the overall statistics of the number of teams that are currently operational and the location they're at. But for example, the next stats are super incomplete. So it's kind of showing you the overall activities, showing you the number of consultations those teams have done. It will show you the referrals that have been done. It will show you the births that occurred in those facilities. But we already know that these data are super incomplete because of the lack of connection. But I just wanted to show you some of these because they can really show you the potential of having those tools in those settings. And I do think in a non-armed conflict setting, they work quite well, but we're now learning with these new conflicts coming up that it's becoming more and more of a challenge. But especially if you look at that last that last slide, it really shows you a lot of really interesting public health statistics. And currently we only look at the health facility reporting. In addition, we also have a lot of rapid response public health teams that also collect additional data, but they're facing even more challenges in actually syncing the data to the coordinating cell. So I hope this wasn't too confusing, because this is a very quick ride across a broad topic. And I do think the Q&A will probably help to answer some of the more specific questions.
Well, thanks, Felix. I've always heard at the periphery of our conversation some of the work that you're doing in conflict areas and in public health emergencies. So it's nice to see it up front. I encourage you to leave questions in the Q&A section if you have any questions. I think one of my questions specifically, you sort of touched on it already, is maybe I have two questions. The first one is around how you actually sustain a public health response using some of these technologies when you are unsure of the infrastructure. So you're using workarounds like Starlink, which have become quite very important in such contexts. But then it also raises questions around capitalist roles in some of these situations. So recent news reports around how Starlink becoming the arbiter of what truth is and deciding who gets to have access versus who doesn't have access to technologies. What are your thoughts in those situations?
Yeah, you're touching on exactly the conversation we always have, is like, how do we involve those tools? Like, for example, the images that I showed from the Portuguese, they use the tool in a non-disaster setting, but at a large-scale event, and their conclusion was, well, Starlink works perfectly fine. But then everyone else said, well, we cannot solely rely on one source of internet in case someone decides to just cut it for us. In my experience in like the non-conflict settings, it's quite often the case that mobile networks are still there. So for example, both in like Moldova, for example, but also in a lot of other settings, mobile cell connection gets restored quite quickly. And even before Starlink, getting satellite internet was possible. It was just a lot more expensive and slower, but it was already possible. And even though it was more expensive, the cost of it wasn't terribly high, because if you consider that the cost of setting up such a field hospital is anything between €500,000 and €2 million, paying another 10 or 20 or 30 grand for internet doesn't really break the bank anymore. But yeah, it's really that, and especially now in Gaza, we've now seen that we need to figure out ways how to do this in other alternatives. So now one thing that's definitely being done is just tossing your data on a thumb drive and getting it to other places where there is connection. So certain spots you can definitely get a connection from Israel, so you just have to have phones and devices with Israeli SIMs in it. But it is definitely becoming also a weapon in armed conflicts to really limit the access to information. So not just for the actual providers, which sometimes can get around it, but all the kind of useful public health tools digital public health tools that we could use in a non-conflict setting can be shut off by just blocking access to these information to potential recipients of your interventions. So for example, in that new hospital that the Red Cross has just set up does not see a ton of patients because a lot of people aren't aware of it, because for security reasons it's not set up right in Rafah but just close to the ocean, and a lot of people that would actually need care don't even know about it because it's really hard to get the information to them and actually make them aware of it.
I have other questions here. So Kathleen is asking, is there a push to have more medical scribes involved in your work? I imagine especially around having patient health records and the burden of administrative burden of actually filling some of these forms. Maybe a scribe helps in that situation.
Yes, that's always an interesting discussion. And the role of a scribe is quite often used by just trying to employ local medical staff if they're available, or even, for example, in the Red Cross movement, we always utilize local Red Cross volunteers for a lot of those tasks. Not so much for the medical documentation, like especially all the registration of patients, getting the demographic data, getting their personal identifiers. That's all done by local staff. The actual role of a medical scribe is not really defined. If it's available locally, that can work, and it sometimes is even a means to get people that are affected by disaster back into a paid employment. But especially in the beginning, that's not really part of it, because sending like international expert staff as medical delegates into the field is already very expensive, and in certain settings, like in conflict zones, it's actually really dangerous and difficult to get them there.
I think if I may interject, I think the question is specifically around AI scribes. So
AI scribes.
Yeah.
No, hasn't really been used. Mostly because we're trying. I mean, long term that could work, but you would have to have an offline tool that would be able to do it.
Yeah. I wonder whether there's any small language model someone might work on to get.
I think long term that should work. You would like, especially for that very limited set of things that you have to report, and you should be able to train an offline model to actually do it. But right now, people are still struggling with other things.
The final question is: are new digital tools these new digital tools being included in the current curriculum? I imagine for the emergency response team, what's the training like? Does it include digital tools?
Yeah, so we included in there's basic training for medical staff that just introduces them to the overall mechanism and to the different components of those hospitals. There is already like a short session that's part of it. We're currently releasing, like for this specific tool, we're releasing an e-learning module, and then there's like a 4 and a 5 day expert user training where people kind of also become training of trainers to then train others in those tools. But yeah, it's the main issue with these tools is that they're not being used on a daily basis. So there's always a learning curve in the beginning, even if you were trained a year or 2 or 3 years ago, by then being able to use it again in the field when you actually deploy.
Yeah. Emphasizes some of the concerns we've had around competencies and continually
Exactly
competencies. Well, thank you, Felix, and thanks to everyone who finally made it to the very end. 3 hours is a really long time, I'm realizing. I hope we've sort of gone through the breadth of what digital public health might look like. Both the positive uses, but also the potential risks and how public health might be better situated to respond to it. It is a really broad field or broad area of practice, and it's something that I'm potentially excited to be engaging with. I hope that you are too. Before we go, I just want to highlight a few things that will be coming up in the next few sessions. So if I can share my screen. So in the next few sessions, we'll be having more conversations around digital public health, but now we'll be focusing more on practical issues. So on June 5th, we'll be discussing digital health promotion. Dr. Mark Gilbert, who leads the Digital and Sexual Health Initiative at the UBC CDC, will be leading a conversation around what digital health promotion looks like, how we can be thinking around the tools that we can use to reach different populations with primary, secondary, and tertiary preventive interventions, but also thinking about what role these technologies play as a new environment that we need to be thinking about. So how the digital determinants of health also play out within these environments, the digital environments. So we'll have more practical conversations in that session. On the 26th of June, I'll be very excited to have conversations because this is a topic very close to my mind. I think we had a few comments here about design thinking and human-centered design. I think one of the gaps in our current training is how do we engage with the process of human-centered design when we're thinking about digital public health interventions. And so we'll be having conversations with product designers, people who've been there and done it within public health context in Canada, trying to understand practical considerations that can be had from a public health perspective. Finally, on July the 10th, we'll be having a team that has done lots of work around artificial intelligence and machine learning for disease surveillance and epidemiology. I think this is a very strong area of practice for the UBC CDC folks. We've had lots of conversations here, but This group will be giving you lots of examples of how they've employed more advanced surveillance techniques using big data to address public health questions. So I encourage you to sign up for these ones when you do see the notices out, and let your friends know also. Unfortunately, today we really have to stay conceptual because it's the first one. It's sort of giving you a broad view of what's going on. Hopefully, in the next few sessions, we'll be a lot more practical, exploring how you may do these things in your own practice. If there's any question, please let me know. Otherwise, we'd like to thank you very much, and we'll hope to see you soon. I think Swati will be sharing with you a link to a post evaluation, a post seminar evaluation. So you might want to share with us what you thought about this session and how we might improve going forward. But if there's no other questions, I would like to thank you very much for your time. And specifically, I would like to really send a heartfelt thank you to all of the speakers who have stayed up late at night to talk with you. So thank you very much.
Thank you. Have a nice day.
Thanks.
Bye, everyone. Thank you.
Okay, thank you so much.